All right, so hello, this is our final genetic presentation for our genetic disorder, and we are doing a 5 to 10 minute presentation on our specific disorder. So let's get right into it. I chose congenital hypothyroidism, as we know, throughout the semester. There we go. So what exactly is congenital hypothyroidism? So basically, I broke this apart, the word. As we know, congenital means basically just from birth. That's the meaning of congenital when we have diseases like that, genetic diseases from birth. And then hypothyroidism means that your thyroid gland is actually underactive, which is that hypo. Hyper would be overactive, but hypo means underactive. So put those words together, and what do we have? We have a underactive thyroid gland from birth. So this is basically a genetic disorder in newborns, and meaning that they don't produce any or enough of the thyroid hormone. Sorry. This can be complete or partial, as I just said. They either produce none or they don't produce enough for it to be effective. All right, so I wanted to include the history of the disorder, even though it wasn't necessary for this presentation, but I just thought it was really cool, my history, for mine at least, because I basically read this article about how this surgeon, Thomas Blizzard, in the 1850s, he basically was a doctor and he had a surgeon, and he had these two patients that were girls, and they both had these really weird significant health issues, including mobility issues, which is problems with their gait, mobility, getting around, enlarged tongue, puffy faces, stunted growth. They had spots on their heads, like weird soft spots on their heads. And obviously back then we had no idea what congenital hypothyroidism was. So sadly, both these girls did die at a younger age, but it was later discovered that they had no thyroid gland at all. So 50 years later, a treatment was developed for this, and basically congenital hypothyroidism and treatment became a thing and became now what we have in present day treatment for congenital hypothyroidism. So I thought that was just a little cool history. So there's some specific major characteristics of the disorder, as I already mentioned. We have that enlarged tongue, the puffy face, the stunted growth, underdevelopment. There's also chronic fatigue, the soft spots on the head, umbilical hernia, hypotonia, which is poor muscle tone. You can usually tell the muscles will be indented, or it's just, you look very almost anorexic in a way. And then also in severe cases, if it's not treated, long-term mental disabilities. So it's definitely a significant disorder. Causes of this disorder is multiple different genes. They will cause this disorder from mutations. So the one I chose for the whole semester to analyze, I think it was for, I don't know, maybe it was project 4 or 3, I can't remember which one. But I chose TSHR gene, which is on chromosome 14. But I also wanted to mention a few others. We have the PAX8 gene, chromosome 2. Those were the two biggest ones I found. But there was also mutations in a few other genes, some that led to dyshormonogenesis, which would be DUOX2, which is on chromosome 15. There's SLC5A5, chromosome 19. There was TG gene, which is on chromosome 8. There's TPO gene, which is on chromosome 2. Then also, there's hormone synthesis disruption. Mutations in genes such as TSHB, which is on chromosome 1. So yeah, obviously that's just a lot of letters and numbers, but just thought it was cool how many different genes being mutated could cause this disorder. But again, I chose to focus on TSHR gene, which is what we're going to look at now. So basically, normal function of this TSHR gene is to produce this protein, which attaches to the thyroid stimulating hormone TSH. So once they attach, TSH will bind to the extracellular portion of the receptor, this protein, and this will result in control and regulation of the thyroid gland. So we know, or should know by now, that the thyroid gland basically is huge in our metabolism, growth, that kind of thing, controlling, regulating. So as you can imagine, if we don't have this binding that happens, which is what happens when this genetic disorder happens, there's the ability to bind to the TSH, the TSHR protein is unable to bind to this TSH, which essentially stops the thyroid from being produced, the efficient amount of thyroid to be produced, and then basically these low levels will either indicate a spike in how much thyroid is produced, and if this spike takes, then that means your body's just compensating for it. However, if not, then basically these low levels, even though your body is compensating by making more thyroid, but you still have low thyroid levels, indicate you have congenital hypothyroidism. And this can even result in actually a smaller size of your thyroid, not just less of it, but also not just less of the hormone, but also smaller size of the actual gland, which is kind of interesting as well. So the mode of inheritance for this. So this is a congenital disorder from birth. So it doesn't spread like a normal infection. This is not like the coronavirus, breathing the same air, airborne, or, droplet, all that kind of stuff. This is not surface, nothing like that, or body fluids. This is basically just from birth. It's a genetic disorder. But the interesting thing is it's not correlated to family history. It doesn't appear to be. So, like if my brother has it, doesn't mean that I'm likely to have it, or things like that. But there was something that showed that in some cases it could correlate to parents having autosomal recessive inheritance. So your parents don't show it, yet you get it, if that makes sense, as we talked about. So again, not a strong correlation, only a few cases, not a few, but minority of cases are like that. Most are just, they happen. So now we have our pedigree, and I was very happy to put this in here because it took me a long time to make, but I'm not going to go over the whole thing because that would put me way over my time limit. But basically this pedigree is just showing that this is a recessive inheritant disorder. And basically, as that means, it can be silent. You won't know that a parent is a carrier and then your child could have it. Or vice versa. If the parent has it, doesn't necessarily mean that the child's going to get it. So I thought that was interesting and just a good fun fact to share about it. The red box in here indicates that that's an affected individual. So I have the probabilities listed and all that. You can go over that if necessary, but we've already talked about it in our past projects. All right, so now we have our genetic testing information. So basically, in order to test for this, a genetic panel is done at birth in the United States and most other developed countries. And this is a heel pinprick in newborns. So they will take a pinprick blood from the heel and do the test that way and check for the TSH levels and the T4 levels, which are your thyroid measuring levels. If that comes back low, let's say, or abnormal, then that could be indication for an ultrasound, and they would have to do an ultrasound of the actual thyroid gland. They can check for the actual levels. When they do that, they get a clearer look. They can see the size of it, all that kind of stuff. So that tells them a lot, and that can confirm the diagnosis of congenital hypothyroidism. So we had to talk about if there was controversy surrounding our genetic disorder, and the short answer is no. There was not really any controversy with mine. I mean, basically, quicker treatment gets you in more effective long-term care, and it can prevent some of those horrible, like I said, long-term disorders or neurologic issues and even death. So the only thing I did find was one article, which I put in my references page. But I found one article that did state within the first couple years, if you were over-treating this disorder, it could lead to causing potentially more harm than if it wasn't treated at all. However, if it's being treated appropriately, that doesn't count, or that doesn't qualify. This is over-treatment. If it's being treated appropriately by, your doctor being followed, then this shouldn't apply. And again, that was just one article. I just thought it was interesting and should mention it. Okay, so now we have the prevention treatment. Basically, there's basically no prevention. I threw in this middle point saying that it was interesting. I found that during pregnancy, if you have hypothyroidism and on a medication, the child could have the disease, could have hypothyroidism as a newborn. However, it usually resolves. So it's not really congenital hypothyroidism, but I just found that interesting. Also, for treatment, we have, like I said earlier, long-term treatment with a thyroid medication pill. And this is usually levothyroxine, and you're probably going to be on it your whole life. And basically, it's not really a debilitating disorder if you keep it under control, which is through regular checkups with your primary care doctor and endocrinologist. So they can adjust your dosage based on fluctuation of how you're doing in your thyroid levels and all. And they'll measure those at regular checkups. All right, and there's my reference page. I hope you guys really enjoyed this. I loved learning about it, and I work in the hospital, so it was really beneficial to me. And like you could probably tell, it was just easy for me to talk about. I found it very interesting. And yeah, so thank you. I had a great semester, and I hope you enjoyed my presentation.